or a crown. It is useless if the tooth fails. For the patient, the tooth has failed. Hence, we have to view everything very holistically. And another thing that I personally believe is that we are lifelong learners. We are lifelong learners, and the master's degree that we do is just the first stepping stone. So, what I'm about to teach you today is not something which I only learned in my master's. It has been refined through practice, multiple practices, failures, learning, and then correcting those failures and gaining experience, which is an invaluable part of dental practice. So, before we start, is everyone comfortable in Hindi? Or should I just be speaking in English?
Hindi, ma'am.
Hindi is fine?
English,
Yes.
ma'am.
English.
English,
Okay. So
common
everyone is fine
language.
with
So
English?
he
Or a
speaks
mix of
English.
both?
Sir, I think
Both, ma'am.
Mix of both is good. That is understandable for everyone, right? In case you feel I've said something in Hindi and somebody is not able to understand, just let me know and I'll translate. Okay? It's
Sir,
just
I
that
think, ma'am, I think English is better.
I'm sorry.
English is better.
Okay, fine. I'll continue in English. All right. So this is my setup, a part of my setup. The full pictures of relatively newer setup I'll be uploading on Instagram, so do follow me there. Now, one of the most important things in my lectures that I have seen is unlearning. That is the most difficult part. Learning is easy. Unlearning the old habits and then adapting to the new is the most difficult part, and that is one thing which I focus a lot on. It takes a bit of practice, it takes a lot of courage, and I encourage everyone here to unlearn what we have learned traditionally and try and embrace the new. And hopefully, you in the next 1 hour you will be having a lot of new things to learn and old things to unlearn. Okay, so these are 10 small habits for stress-free and most importantly, profitable endodontics. Now, I read this line somewhere that dental practice is too tough to not gain financially from. And I personally believe that we do a lot of hard work. We work in a very, very small contained space. Our necks bend, our backs bend. We need to really, really be earning well from it to make it worth our time. And obviously, it has to be stress-free for us to go about it our whole lives. Now, first thing that I want to discuss before we go on to the 10 habits is why am I doing a root canal treatment? So the reason I'm doing a root canal treatment is very simple. I am removing the infection and I want to prevent reinfection and prevent fracture, right? I want the tooth to not fracture. Now, infection can be due to bacterial causes, that is cavity, caries, or non-bacterial causes, which may include non-carious cervical lesions, which may include cracks, which are one of the very, very common reasons for teeth to go for root canal treatments. Now, we'll focus on the bacterial causes for today. So, bacteria enter the root
Hello?
canals through
Ma'am,
what?
video is not clear actually. The screen is
sorry.
not visible.
This
Screen is not.
Screen is not visible. We can't read.
Is it better now?
Yeah, it's okay now.
Can you see?
Yes.
Can you read what is on it?
A little more. Can you zoom little more?
I cannot hear you, sorry. Huh?
Yeah, it's okay.
Yeah, that's fine. Okay.
Yes.
Okay. So I believe that the screen is now visible with a little less visibility of me, but I think the screen is more important. Okay. So what do you think is the main cause that root canal treatments fail or bacteria remain inside the canal. Out of these five, which is missed canal, broken instrument, incomplete DMP and irrigation, perforation, and poor post-endo. Out of all of these, what do you think is the most common reason for root canal treatments to fail? Anybody? Even if you're comfortable with the chat, just mention it in the chat.
It be MP and irrigation.
Sorry.
Then option third, incomplete biomechanical preparation and irrigation.
I cannot understand the question. I didn't understand.
Improper coronal seal.
Okay. Improper coronal seal is actually correct. What else? Anybody?
Incomplete biomechanical preparation and irrigation.
High point.
Anybody else?
High point in cap.
Poor post-operative restoration.
Is it's not a cause of failure per se, that is a cause of discomfort for sure. Right now, we are concentrating on the failure part. That what causes the bacteria to remain or re-enter, right?
Poor
If my root
post-endo
canal-
restoration.
Yes, that is one. That is absolutely correct. Improper coronal seal is correct. Now, coming to what actually it is. So, the ones who answered improper coronal seal and the post-endo restorations are absolutely actually right. They are absolutely right because basically what happens is there are main two reasons for the root canal to fail or the bacteria to re-enter. One is incomplete BMP and irrigation. Either we have missed a canal or BMP was not complete, pulp remained, necrotic pulp bacteria, etc. biofilm remained, and it again reinfected. The root canal treatment failed. And the second reason is poor coronal seal. So by poor coronal seal, I don't only mean the crown. It is the post-endo restoration. There was a very interesting study, I'm sure some of you must have read that, and I think most of you might have heard of it, by Dr. Trope in I think 2004-5. He had actually evaluated what is more important, a apical seal or coronal seal. And the surprising result was that if you have a poor apical seal, but you have a good coronal seal, your root canals will still last a long time. I'm not advocating anybody to have poor apical seal. I'm just saying that coronal seal is that important. So you need to have a very, very good coronal seal, and I've seen a lot of people leave behind ZOB or use GIC as a post-endo restorations. None of them are good enough. The acceptable post-endo restorations for today's endodontics, modern endodontics is composite, and even better is dual cure core build-up material. But we'll learn about it maybe in the next lecture. Okay, so the three most important factors which we need to focus on are you have to locate all the canals, you have to do a proper BMP and irrigation, and your post-endo plays a huge role here. Now, what do we want to achieve? Now, one of the things that is there is that the goal of being healthy or of treating the symptomatic tooth. Like today morning, I had a young girl who had caries and has to go for a root canal and crown. What would I tell her? That okay, I will do a root canal treatment and the pain will go away and I will fill the gap and there will be no gap and I'll place a crown so you'll be able to chew. So the goal is healthy, should be no infection and symptom free. But there is one part missing here. What part is missing? The missing part is, which is our habit number 1. It is the patient's responsibility of making the RCB last long. It is obviously partly your responsibility to do a good root canal, but also it is the patient's responsibility on how long the root canal treatment lasts. Now, how long do you think this root canal lasted? I have not done it, by the way, but how long do you think this root canal lasted? Can anybody guess?
20 years.
Okay, not bad. What else? Who else?
Yes, 20.
4 to 5
Sorry.
years.
Whoever is speaking, your voice is very muffled.
Some very short obturation in mesial canal, no?
Yeah, there are a lot of faults here. There's a short obturation, and there's a lesion.
And
So
palatal
how
canal is
long,
also palatal and
how long
distal
do
is
you
also
think this root canal would have lasted?
not more than 5 or 10 years.
Not more than
5 or 10 years.
5 or 10 years. Okay, so this banger actually lasted 32 years. And I'll tell you why. Because the patient had an impeccable oral hygiene. That is why I say that it is not only on me. Root canal, how long will the root canal treatment last? So when a patient asks that, my answer is how long you will make it last. I will do my best. I will do 110% of what I can do. The remaining is on you. You have to brush, you have to floss, you have to basically maintain your teeth well, you have to not chew sugar cane on it, you have to not break walnuts or open bottles with it. So a lot depends on the patient, and the step one is the answer to the question is how long the root canal will last. It is the patient's responsibility as well. And the patient I showed you, he had a very high caries rate. And all of the crowns, restorations, etc. last a very long time in his mouth because he has an impeccable oral hygiene. Okay, we go to habit number 2. The habit number 2, the habits we're discussing right now are actually pre-endodontic habits, which is before starting the root canal, what I need to keep in mind. So where to do a RC and where not to do a RC. Now, obviously, this depends on the condition of the tooth, that is, how much destruction of the coronal structure is there, what other concomitant disease is present. So here, this tooth. Sorry. Yeah. So this small central incisor here. Do you think that a root canal should have been done there? This one. Do you think a root canal should have been done here? Yes, no, maybe. As you know, I have done the root canal. But do you think
We
I
can
should have done it?
try.
Sorry.
We can do.
Okay. How long do you think this lasted? Any guesses?
Maybe it's still present. Is it still lasting?
Sorry?
Still lasting.
Still lasting. Oh,
Root-
you are a very nice person. I wish that was correct. This lasted 2 years and it fell out of the patient's mouth. That is where the importance of concomitant disease comes. Perio. Never underestimate perio. This tool I should not have saved it. This was done when I was fresh out of PG. And I was under the impression that I can probably save everything with endo, which is not true. Hence. Now, how do you decide what tools, in which tool would you do a RC or not? Like I said, patient wants a tooth back. They don't want good endo, right? Obviously, they want good endo, but nobody comes and says, give me a good obturation, right? They want the tooth back. They want the tooth restored. They want to chew on it. So, do you think that these teeth, this premolar here and that molar there, do you think I should have done root canal in them? Yes, no, this one. This one and this one. For the premolars. For this premolar, how many yeses do I have? Yes, no. Anyone?
Definitely yes.
Okay. What about the molar?
Yes.
Okay. So here, what I would like to say is that we have to first see if the tooth is restorable. And it has to be restorable margin wise. What do I mean by that? You remember Krasner and Ramco's laws? The floor of pulp chamber lies at the level of CEJ. right? The floor of pulp chamber lies at the level of CEJ. CEJ in this tooth is here, and the caries is going below CEJ. If the caries is going below CEJ, it is obviously on the root. So whenever you see caries going below floor of pulp chamber, okay? Whenever you see caries going below the floor of pulp chamber, like the floor of pulp chamber is here, this caries is partly, slightly below the floor of pulp chamber, that is root caries, and here the restoration obviously becomes questionable. Okay? The restoration obviously becomes questionable. You can say it. Sit. Not a problem. You can sit here. Okay? So the restoration obviously is questionable because I cannot see on the root surface. Right? Okay. Let's see the next one. This is an easy one, right? We can save this because it's fairly easy. This thing is a very ideal cavity. We are good to go. Next one is interesting. Okay, this 7, upper 7 in the corner. This one. Do you think I can do an RC here margin wise? Because like I said, patient wants a tooth, I should be able to seal the margin. If the margin is on the root, I cannot seal it predictably. If the margin is on dentin, I can seal it predictably. So in this one, do you think we can in the 7? Do you think we can do the root canal? No wrong answers here. Anybody? Is anybody there or has everyone left? I don't know that. I cannot see the screen.
Molar is restorable, I think.
Yes, you're absolutely correct. Because this is a badly angulated X-ray. You can see the floor of pulp chamber is here and the caries is well above that. So this is fairly restored. Okay, and it's very good prognosis to be honest. What about this central incisor? That is a favorite. Do you think I can do a post-endo and save this? This is right at the gingival margin. Can I?
Yes, it can be done.
Difficult to
Okay.
say.
What do I need to do for that? To save this tooth, ठीक है, DRC तो I have to do. That is for sure. But what else do I need to do?
Post-core and CLP.
Okay,
Build
post
space,
I have to do.
post and core, yeah.
Ma'am, we can go for crown lengthening.
Yes, that's absolutely correct. So
Correct,
in
yes.
these cases, it is only savable if I do a crown lengthening to gain 2 millimeters of healthy root structure. Okay, otherwise this thing will break, and it did break because I did not do crown lengthening. So I need to lengthen the crown, gain 2 millimeters of root structure, so that when my final crown comes, it will be something circling the entire tooth. So this would be somewhat my final preparation. The orange, this part being a healthy crown structure, this part being the healthy crown structure, post here, over here, and my crown will be enveloping the healthy tooth structure. 360-degree ferrule is needed for me. On healthy tooth structure is needed for me to save this. Okay. So you cannot just save it with a post core. I have done that. It has failed after that also, and I don't mind. Can I save this? The broken molar. No, I cannot save this. It's futile.
Not
saving
really.
this. Okay. Another thing, Pre-endo.
Have to do root canal or not?
Sorry.
In root caries cases, will you suggest do root canal or not?
What?
Takes into account caries.
Root caries cases, in root caries,
Yeah.
so we can do, can we do root canal or not?
No, root caries case is extract. I cannot see the margin predictably. If the patient is like, okay, I'm paying you a lot of money and it's okay if it fails in 1 month, then go ahead. But usually extract. Root caries cases, there's no point in even attempting the root canal because you cannot see the margin. Hence, no point.
Ma'am, a doubt. Can we expose the the margin which is not accessible and then treat to it, and once it's done, then we restore it?
How do you make it accessible?
I mean, by removing the
Margin elevation.
tissue.
Can you repeat, please?
Ma'am, if there's a case of root caries, can we expose some part of the area where root caries is inaccessible, and
There's a
then
case of root caries and
expose it and then treat to it? Once it's restored properly, then we have a intact margin which can be tended, and then we can treat the tooth as a normal tooth without root caries.
no, but the thing is that it's not about the margin being exposed. Okay, it's not about the margin being exposed or not. It's about not being able to bond to the root dentine and cementum.
Okay.
Right?
Okay.
There will be leakage there. See, if you can expose the margin and all that, there is a whole other issue of biological weight, etc. Okay, we can always change the biological weight. We can do a crown lengthening with bone removal and everything. That all is fine. But the fact is that you still cannot bond to root dentine predictably. And these cases basically fail at a faster rate than you would bond to coronal dentine. That is the reason we don't do RCTs and root caries.
Okay.
Because
Thank you.
we cannot bond there. If I can access it, like suppose you have a gingival recession patient,
Yes.
right? So even then, I would tell the patient that I don't have much hopes for this. Because even
Okay.
though it is exposed, it is going to, again leak after a while.
And could we
So-
not use a material like bioactive material like biodentin MTA placed there, because we use it within a deeper lengths of the tooth? So what if we can use it on such places and then use another material which can bind better to the MTA or biodentin rather than binding directly to the root portion of the dentin?
I did not understand your question. MTA, biodentine, like you're planning to basically bond and make your margin with MTA.
Ma'am, a little layer of MTA, because you said that, which is true, that there's a issue with bonding to the root portion of the dentin. But what if we apply one layer of MTA and then restore it with the other restorative materials? I mean, can it work? Is it a possibility?
I've never tried that. If it works, let me know also.
Yes, ma'am.
I've never tried it, but
Yes.
I have my doubts because I don't know how much it will be able to take the load of occlusal load. Eventually there on the post-endo, in the cervical margin, you will have occlusal loads.
Yes,
So
ma'am.
how much of occlusal load will that MTA be able to take? How much would be required? That all needs to be investigated.
Yes, ma'am.
So maybe it might work. I still have my doubts. So in clinical practice, if the patient is not hell-bent on basically saving the tooth, I would go like extract and get a bridge or an implant. Make it
Yes.
So you
easier
don't,
on make it easy on the
so
patient.
you, so you won't even recommend hemisections also?
Hemisection. See, in my practice, if you're talking academically, hemisection is a good procedure, right? But in my practice, if you look at the surgical aspect of it and the financial aspect of it, patients somehow are way more comfortable that, take it out and place an implant. So that is
Hemisections
that.
and bicuspidization can be tried, I guess, like instead of completely going for extraction, we can, because most of the times patient won't be ready to get the teeth extracted just because it is
So-
almost in Indian scenario, we get almost maybe 2 to 3 cases will be having root caries. For all the cases, we cannot recommend extraction, I guess. We have to be little conservative. What do you say?
So, see, if your practice patients are ready to understand the hemisection that works well for you, go ahead with it. It's a legit procedure. It is not something which is not to be recommended. In my practice, I feel that patients who are against extraction, they don't want any part of their tooth removed or sectioned or anything. So, there they ask me, this is also surgery in a way. This is like extraction only. might as well get it removed and place an implant. So, there. Plus, I personally feel this is completely a personal choice. I personally feel the more long lasting and final restoration or a final result I can give the patient, the better my reputation and the patient retention is. So hence, and I don't like giving something which I myself am not sure how long it will last. So that is one of my reasons. But yes, if patients are willing to understand hemisection, it's a good procedure to recommend for saving teeth. That's
Yeah.
not a bad option. That's a
Yeah.
totally legit option.
Yes.
Okay, so we go ahead. What? Hold on. Okay, so now we move on to the second thing. So do you think this yellow arrow tooth I can save?
Yes, ma'am.
Okay. What procedures do I need to save the tooth?
Root canal followed by post and core and then full crown.
Root canal and
Post and core followed by full crown.
followed by full crown. Do you think a post and core only is enough?
Sorry, ma'am.
Do you think only a post core is enough?
Or maybe reinforcing it with ribbon.
Crown lengthening.
Maybe what is enough? I did not catch that. Can you please repeat?
Crown lengthening.
Yes. So again, here the root structure is fairly robust, but after I remove all the caries, I will just barely have a very teeny tiny portion. I will have a very teeny tiny portion of this part left, right? And after crown removal, hardly anything will be left. So I'll have to again do a crown lengthening procedure. Okay, if I really want to save it. And like I said, in my practice, my patients generally want a simpler solution. So since they want a simpler solution, this patient opted for extraction and implant. I'm not saying that you cannot do crown lengthening and post core. I had actually offered that to the patient, but he was not going for such a long crown procedure. He wanted something similar. So always assess what it would be like after removal of caries and after crown preparation. Then only go for a root canal. So for this patient whose RCT lasted 32 years, so he came to me because his crown broke. The crown also lasted 32 years. Now, what do you think? Should I do a root canal here or just change the crown? He has no signs and symptoms.
No
No,
reason.
no root canal.
Only
Ma'am,
change the crown.
ma'am,
Only
as
change
it
the
is an,
crown.
ma'am, as it is an,
Why? Why?
Ma'am, RCT and
I did not understand why.
Ma'am, slight radiolucency seen in the distal buccal root. So there is a symptom.
No, I'm asking, should I do a re-RCT here or should I just change the crown? He has no symptoms.
I mean, you should just change the crown according to me because it's been such a long case, so that it would be a proper zone of without bacteria. So and it has a proper seal. So rather than changing and risking again infection, we should just change the crown according to me.
Okay, so what so here is where I differ. If I can see a
Or maybe we
periapical
could
lesion,
go with
huh?
re-RCT, selective re-RCT, only for one root wherein the obturation is short. We can only go for selective re-RCT only for that root, and then we can go with the crown without exposing the gutta patkas of the other two canals.
Okay, so again, this is where I differ. So first is that I would do a full RCT, re-RCT, which
Explain
I
the
did.
patient about bone treatment and ask them to select the treatment procedure.
You can, but as a doctor, what would you recommend? So that is my question. So here, as a doctor, I recommended him full RCT along with crown, because see, the way I see it is we are dealing with bacteria. If the bacteria has infected the GP in the mesiobuccal, it has probably infected the GP in the deep distobuccal and
But ma'am,
palatal
also the
as
distobuccal
well.
canal is obturation is also short now.
The distobuccal canal, right?
Yeah, because the
Yeah, so I
mesiobuccal,
went for a full RCT.
mesiobuccal and
This is
distobuccal canal obturation is short.
Yeah, so I went for a full RCT here, which is this. I went for a full RCT and I then changed the crown because I am never comfortable wherever I see a lesion. Even if the patient has no symptoms, I am not comfortable leaving the tooth without a RC. Obviously, if the patient doesn't want, then we can perhaps give a crown, but in those cases I am still very selective. I would rather let the patient go, but on to that later. But wherever you can see a lesion, do an RCT, do a
Ma'am,
re-RCT, not even a selective
which cone you
re-RC.
prefer in palatal, 35/6 or 36?
What do I prefer in?
Palatal canal, matlab how much you obturate in the 36% or 35/6%?
I don't do 6% at all. I do only 4%. So for the palatal, my preparations usually range from 44% to 45.4%. 35 to 45.4% is the range. I don't do any 6% because I don't feel they are necessary. And I feel that we are being more conservative with 4%. And as long as I can irrigate properly with 4%, I don't think I need 6% at all.
Okay, ma'am.
And
If we
this,
are using 6%, more portion of the tooth is cutting.
yes, if I use a 6%, then I'm cutting more portion of the tooth. That is why I would basically use a 4%. I use 4% everywhere. There's hardly a case where I use 6%. Okay. So, yeah, tell me. Anything? Okay. So I got this referral case. Again, case is same. Patient basically lost the crown, the RCT or the lack of RCT, whatever you can call it, was done 10 years ago by a very senior practitioner actually. But the doctor, the patient went to this time, told him that he needs to do an RC because RC was not done. Now, there is extreme calcification. All the canals are calcified. We took a CBCT, we found no lesion on the CBCT. Patient also has no symptoms. Do you think I should do a RCT here? No signs of lesion, no signs of infection, no symptoms, just a broken crown.
Ma'am,
Should
it
I
is an
do
asymptomatic irreversible pulpitis. We should go for RCT, ma'am, as is indicated for RCT.
and indicated for RCT by?
Ma'am, it is an like a asymptomatic, but it is since it is an irreversible pulpitis is like it might be necrotic.
But it's not. It's CBCT.
अभ्यासामुळे मसाला आला तुझ्यामुळं तू होता ना माझ्या बरोबर
I don't think RCT is required.
दिलं नाही तू का किती 40 आहेत का
Okay, so here what I feel is I did a RC, but really I would feel that if this tooth has lasted 10 years without any signs, without symptoms, the CBCT also indicates there is no lesion whatsoever, I would leave this tooth. I would inform the patient, I would leave this tooth. If the CBCT confirms no apical widening, no lesion, I would leave the tooth. No symptoms. There are no symptoms. There are no symptoms.
Someone is
There is no
disturbing the
sign.
voice.
Kindly mute the
He
furnace.
said, somebody speaking. I'm not able to understand you if you are.
Mute
Or maybe by mistake you put yourself on unmute. Okay, so here I would say that if it's extremely calcified, there is no pain, no sign, no symptom. you can also let the patient be after informing the patient. If, like in the previous case, we had signs, it's a rehearsal. That is clear. Okay, we move on to habit number 3. Doing RCT just because the tooth is TOP positive or is sensitive is a big no. And I'll tell you why. So, what does TOP positive mean? Or what does actually sensitivity mean? Now, TOP positive basically means damage to the periodontium, damage to the apical periodontium, right? Now, the apical periodontium can be damaged by caries, it can be damaged by crack, it can be damaged by occlusal overload, it can be affected by recent ortho treatment, attrition, bruxism, periodontics, a lot of things. It can also, you can have only TOP positive in cases where you have the patient chewing on that single lone tooth and patient will only have TOP. Obviously, because the periodontium is overloaded, right? So just because the periodontium is overloaded, I will do a RCT that is not correct. I have to find out why the periodontium is overloaded. And the same actually goes for sensitivity. What does sensitivity mean? Now, the thing is that for the patient, no. Whenever the patient has periodontal damage, they will tell you when I bite, I feel sensitivity. Because they cannot differentiate between periodontal pain and sensitivity. To them, this appears sensitivity. And this is the reason when sometimes after placing the crown, patient comes back, everything is perfect, your RCT is perfect, everything is perfect. The patient places the crown, comes back and says, crown, after the crown, I'm having sensitivity. They are not having sensitivity after the crown. They are having high points, maybe lateral movement issues that you need to adjust. The periodontium is getting overloaded, and that is what they are feeling as sensitivity. So after the crown, if a patient comes back with sensitivity, don't just start removing GP and things. Evaluate the crown first. It is mostly that. Okay, so another thing is, like I said, look for the cause of the sensitivity, and I'll show a case. Why? So, this is a young woman. She came to me around 5 years ago. She had discolored centrals, and that is because she had gotten RCT done in those centrals like 5 years prior to that. And I had asked her, why did you get RCT done here? You don't seem to have cavities or anything. She said, no, my these two centrals suddenly started feeling sensitive. So 5 years ago, she came to me for just an aesthetic purpose. She said, I just want like a veneer or something to cover the discoloration because she was getting married there. And the reason she had gotten the RCT
Bleaching.
was just sensitivity in the centers. Now, can you tell me what was the actual reason of her sensitivity? And I can tell you it is
Trauma
not
from
the-
occlusion.
Huh?
Trauma
Sorry?
from occlusion.
Yes, you're absolutely correct. Because she returned 3 months later with this. She fractured one of her centrals and the sensitivity had returned, she said a few days back. And after that, suddenly the tooth started feeling loose and it fractured. So now she has agreed to ortho treatment, which I had advised her 5 years ago and is undergoing Invisalign now. So that is why she should not have been treated via endodontic treatment like 10 years ago. That she should have been treated orthodontically. That would have corrected the sensitivity. That is why I am telling you to not treat every case that is sensitive with RCT because sometimes it is just not that. Okay, now habit number 4 is again a pre-endodontic habit because this is where it is most important.
Ma'am, what
What
can be the treatment done for that case?
Which
If you
case?
don't do an RCT, what can be done?
Ortho. Trauma from occlusion, right? She has a deep dive.
Ortho treatment.
Ortho.
Oh,
She's being treated by, she's being given aligners, Invisalign. So ortho is the treatment. Like it should have been done 10 years ago. It would have saved her a central incisor.
Sorry to
Yeah.
interrupt you, ma'am. But for that initial case, usually patients are reluctant in getting ortho treatment, thinking that it will take a longer duration of time for their ortho treatment to get completed. So if the patient asks for immediate treatment, what do you think should be the immediate treatment plan?
So immediate treatment plan, you can just give her over-the-counter desensitizers and tell her the sequence that will happen. That is what I see. I had told her 5 years ago also when she had come for 10 years that you will fracture your central incisor. And the only reason she came back to me was because what I said turned out to be true. She fractured her tooth. So you have to tell the patient that you can take desensitizers, you can take whatever mouthwashes you have, you can have ACP gels applied, anything. But you need to get the bite corrected. If you don't get the bite corrected, your teeth are going to get fractured. And usually I have seen, once you say this, patients genuinely convert for ortho, maybe not immediately, maybe 6 months later. For her, she really didn't believe me, and it happened 5 years
Ma'am,
later.
do you think relieving PFO then and there by like selective grinding, like not like just one or two strokes of burr can be done at that moment of time?
It's extremely big. How much would you reduce? Right? How much would you reduce? It's not, unless I chop the central incisor down to the cervical third, it's not going to be okay, right? See the amount of deep bite, the entire
Even this case is
central covers.
difficult in ortho also, since it is severe deep bite.
It is
Difficult in normal ortho also because it's severe deep bite.
no normal as in no sensitivity is normal. You should not be having sensitivity. Severe deep bite requires immediate correction. It is one of the most what do you call it, dangerous things, because if she doesn't get ortho, if she had not fractured her central incisor, what other thing could have happened? She would have dropped her teeth. Eventually, at the age of 55, she would be getting an FMR. That's what happens to these cases eventually. She will start grinding down either her lower centrals or the palatal of her uppers, mostly both. Then have aesthetic issues, then have fractures on the posterior teeth, and eventually all the teeth, because of the federation, will one by one start going for RCTs, causing pain, and she will have asthma. So I don't think you can ever leave a severe deep bite like that. You have to treat that severe deep bite orthodontically. Otherwise, they are going to face problems. There are some people who are okay, fine, I will face problems when I'm 55, that's okay. Okay, that is their fault. But for a young girl who's not even 35, this girl is not even 35 right now, to lose her central incisor is fairly serious. And these things happen very frequently. Okay, so in this case, very lower 7 exposed because of an impacted 8. What would you treat first? Patient has come with severe pain.
8 extraction first.
Extraction of 8.
Okay. Why?
To stop the reabsorption of the other tooth, adjacent tooth.
Okay. But where do you think the pain is coming from?
It is because of 7, but then treatment of 7 cannot be carried out until and unless 8 is extracted.
No, that's not true. So here, basically, the pain, whenever in these cases, very rarely the pain is from impaction. The pain is mostly from the exposed 7. And you can always do an access here. No, you cannot complete the treatment, I agree, because of the 8, but you can do an access opening in BMP. Once the access opening BMP is done, patient's pain is gone. In the same visit itself, take out the 8. And after like 2-3 weeks of healing of the 8, you will complete the RC and well to do. The reason I will always
But it's
go for
surgical
a access
exposure, no, ma'am. How can we do a RC treatment and surgical exposure in the same case, like at the same time?
by funding. 7 doesn't need to be surgically exposed. 7 is standing on its own. 8 needs to be surgically exposed. So for 7, I would do an access open BMP, and once the access open BMP is over, then I will open surgically. If the patient is not willing, then we'll do it in the second visit. But I have done. But
Can
I
we do
usually
the
do it in the
surgical
same
extraction of
patient.
8 after placing crown on 7.
You can't
Now
place a
that is difficult.
crown at the 7 when it is already being pushed.
Yeah, so that's the first visit of RCT for 7 to relieve the pain, take the 8 out, then complete 7 RC and crown. That is how the ideal thing works. What will happen if I extract the 8 first? The
Ma'am,
patient will be in severe pain for the next 3 weeks, will not be able to open their mouth, I will not be able to do the access only. And
ma'am,
patient will say, yeah.
Ma'am, I will explain the patient, ma'am, that the caries has been due to food impaction because of impacted 8, where you can't able to maintain oral hygiene. So we will open the access and we will not do BMP in the first visit, and then we can go for extraction. Then we can go for complete RCT after extraction.
Why not do the BLP?
Ma'am, BMP like ma'am, I think we can, as a distal caries, ma'am, it requires so much of tooth removal. So it requires definitely an full coverage after doing completing the RCT.
No, I meant why not do the BNP in the same visit as access opening?
Yes, ma'am, like a single visit, if we prefer for single visit, we can do in the same visit, matlab, if you have preference.
Yeah, see, the first thing is that pain relief comes not from access opening. Pain relief comes from removing the pulp. And pain relief
Yes, ma'am.
will come only when you do the BMP. And do the BMP
Yes.
means full BMP. For me, a full BMP is up till 25% minimum.
Yes, ma'am. Yes, ma'am.
Okay. So,
Yes, ma'am.
but if you can do the access, you can do the BMP in the same visit. Do the access, do the BMP, then extract, patient will be fine. If I extract and not start the root canal, patient will be in pain for next 3 weeks because healing and mouth opening will take that long, or at least 2 weeks or whatever. And patient will come back and say after extraction of 8, so much pain, I'm never getting any tooth extraction from you. That is how it
Yes.
happens. So actually, the surgical extraction of 8 doesn't cause that much pain. It's the 7 which is actually causing pain. So treat the cause of the pain from 7. The 8 will heal in 1 week. Like patient will be
Yes, ma'am.
completely fine. After the surgical extraction, patients take 1 week or 10 days of issues very nicely. Okay. Now, how do you decide in any case? Suppose that sensitivity is by case, right? And in the other TOP positive cases where you cannot see KPs or you cannot find a crack, how do you decide whether you have to do a root canal or not? The answer is a cold test. Whenever you are confused whether you should do a root canal or not, you do a cold test. A cold test is the most easiest test to do, and I'm not asking you to fill syringes and put it in the fridge. Just take endo ice by cold tea, spray it on a cotton tweezer. First, the process to do it is this: spray it on a cotton tweezer, apply it on a normal tooth. See the patient's reaction. They used to read in Grossman, no, 5 seconds up, 5 seconds down. That doesn't hold anymore. You see the patient's normal reaction. I've had patients who basically yell as soon as I touch the tooth, and I've had patients who I've been holding there for 10 seconds and they're like, oh yeah, I can maybe feel something. You have to assess the patient's normal and then touch the cotton pellet to the affected tooth. Take the cotton pellet to the affected tooth and then gauge their reaction. Compare it to the patient's normal. Whenever you are confused, compare the cold test reaction to the patient's normal. Cold test is here because it's one of the best tools that we can have for diagnosis, whether you need to do a root canal or not. Yes, you can go ahead. Okay, now I get this a lot. There is a periapical lesion, you started the root canal, you did the PMP, and now you are wondering when to do the obturation. So you obturate as soon as the canal is dry. You cannot wait for the lesion to heal. Lesion healing will take 6 months to a year and maybe more. So this was a patient who lived in US. He comes to his hometown here in Kolkata for like a month in a year. He had these 2 RCs. And you can see this is the master pole X-ray. The lesion is still there, but I have obturated. That is because the canal is dry. As long as the canal is dry, you can obturate. You don't have to wait for the lesion to heal. And the third X-ray is after 1 year. The lesion has healed completely. So lesion healing will take its own time. You don't have to wait for the lesion to heal and then to obturate, because then you will be waiting for 1 year.
This case,
This
can we
is
use
his,
bioceramic sealers?
yeah. Yeah, tell me.
In this case, can we use bioceramic sealers?
Yeah, I can use bioceramic sealers in all cases. I use in all cases. Why would you use in all cases? They are very easy to use. This is after 1 year. So healing, gingival healing also takes its own time. This was the immediate, and this is afterwards. Okay. Now, one of the important things that I have learned for basically myself, because whenever a patient with a lesion, comes on follow-up and we still see a lesion, we are like, okay, what did I do wrong? Is the case failing? That is not always true. You remember we used to have this whole chapter on medical history. The reason we had that was this: perivital lesion healing is slower in certain cases. In which patients? In patients who are on SSRIs, for depression, anxiety, SNRIs, so gestal vaccine, all of these medicines, peroxidine, all of these medicines will slow down perivital healing. Diabetes, even controlled diabetes, will have slightly slower healing. Liver disease, this is one of the most common. Liver disease, even thyroid, patients who have high TSH have very slow healing. Stress is obviously a factor. You have bruxism, that is there, perio issues. And also patients where you have extruded calcium hydroxide, they will have slower healing. So whenever you see a perivital lesion which is healing slower, assess whether the patient is taking SNRIs, SSRIs, has liver issues, is a diabetic, multiple other things before questioning whether the root canal is failing.
What is SNRI and SSRI?
Those are antidepressants, anti-anxiolytics, anti-anxiety medications.
Okay.
So if a patient is taking something like paroxetine, which is common, then you have escitalopram, which is very common these days. You find desvenlafaxine, these are very common these days. So what I do in my practice is I get them to fill a medical history and preferably write down the medicines. If they cannot write down the medicines, I mostly ask them to, go home and just take a picture and show me what medicines you take. So there I'm kind of aware that if I'm doing an extraction, or if I'm even doing a root canal, is gonna take time to heal. And I learned this the hard way in a lower 8 impacted patient. She actually did not have a very severe impaction or something. The tooth was out in like half an hour to 40 minutes, and it was fairly easy, but she did not heal for a long time. And continuous pain, I thought it was a dry socket, I'm giving all those alveol gels, ZOE, nothing is working. Then I asked her to get blood tests done. I had asked her to get blood tests done before also, but she had used some local lab which was giving her a huge discount. And on that, everything looked perfect. Then I asked her to go to a standard lab, there's a good lab in the city, and whose results, we can trust. Turns out her TSH was sky high. The minute she went to the endocrinologist, got that under control, the lower 8 socket healed beautifully. So we really have to be careful in these scenarios. Okay, habit 6. Signals, you need to have good back position. This is not dentistry, and that is not at all dentistry. Please do not do your root canal standing. Whenever, even if you are doing with naked eye, under the microscope, under the loop, 12 o'clock, or maximum 11 o'clock. Now, this comes as a shock to most people. There is nothing called as direct vision. Even your lower sixes, if you see in direct vision, your back will break in 2 years. Please do not do that. I have paid physiotherapists and suffered. So please do not do that. Use mirrors, take the 11 o'clock or the 12 o'clock session. Now, what my root canal treatment set contains. So my root canal treatment said restoration said whatever other endo procedures or resto procedures I'm doing have the same things. One is a good front surface mirror, which I use either relax or whichever good mirrors I find. Now the two things which I really advise to invest on is a good PG16. Either take 250 or Dentsply. They are expensive, yes, maybe 1500 per instrument for now, but they will last you a very long time. I have two Dentsply PG16 which have lasted me 8 years and more. Same goes for spoon excavators. Spoon excavators are actually a set of 6. Spoon excavators come in a set of 6, and the ones that are mostly used is 13, 14 and 11, 12 if I'm not wrong. Take them from 250. I think Dentsply has stopped manufacturing them. They are worth it. Once you, like in especially in restoration cases, where you are unsure how much caries is remaining and etc. I don't prefer using caries detecting dye, so you can use that. But these spoon excavators are excellent. If there's anything left, they will take it out. So invest in a good PG16, a good front surface mirror, and good spoon excavators. The rest, Explorer, plastic filling, use whatever. And GDC is not good for DG16. I have had many of them. They are too thick. They will not help you locate the canals. For upper 7, now I use a scope. So my position is always 12 o'clock. But the same thing holds for anybody using loops or even with a naked eye. You go on 12 o'clock or the 11 o'clock. Now, this mistake I see very frequently. People position their light, chair light, people position here. That should not be your position. The upper 7 will not be illuminated directly with your chair light. Your illumination has to be perpendicular to the mirror, and the mirror will be sitting in the premolar area on the opposing arch. And the light reflected from your mirror will illuminate the upper 7, and you will be able to see much better, and preferably use a rubber dam or even those Optra dams, single-use dams that come. They are also decent because you get cheek shadows there. Once the shadows are out of the way, it will be much easier. Okay, now habit 7 is a personal favorite. I advise everyone to use magnification. It's a true game changer. If you have used loops or are using loops, good for you. And if not, please start. You can start with those loops that come from Endoking, the simpler Endoking loops at 3K, they are also decent. So the best thing is to get something custom made for you. But yeah, if not, then at least use those. So this is my setup where I basically show my students the procedures and the scope on a big screen so that it's much more easily visible to all. And obviously visibility increases dramatically when you use loops or a microscope. What happened? Sorry. Happened. Yes, we were here. Yeah. So dental loops are basically like investing in your career longevity. The more you can have your back straight and your neck straight, the longer you can practice without paying the physiotherapist. Now, a good magnification note to start with is 3.5x. You can have them in any company loops you want. Whichever is who have a good service in your area, they are good enough. But please don't sit like this. You will have a lot of neck and back issues, and once they set in, they never go away. Now, loops are of two kinds. This is a very basic info on the loops because we have less time. One is your flip up. So these flip-up style are the general ones. So suppose if you were in your clinic and you and your spouse are both dentists and you want to invest only in one loop, then you take flip-up because you can actually change the interpupillary distance according to your eyes. Interpupillary distance is where the lens will be placed. Like you have for specs, similarly you have for loops. And if you want to invest a little more, then go for through the lens, or even better, ergo loops are coming. So ergo is even better. A good ergo loop, I think, is by IDS. If I'm not wrong, it's fairly budget friendly, even though I can't comment on the quality. So ergo is like this, right? For loops, you have to bend your head a little, but for this, you can just keep your neck straight and it's like a tiny microscope on your eyes. So ergo loops are excellent and I would highly recommend them. They're custom made for your eyes, so obviously apart from you, nobody will be able to use them. But they are an excellent option. And like for magnification, the higher you go, the field of view, how much you can see decreases. So in the microscope, I see something like that, right? So for endo, it is excellent. For restorative procedures and endo combined, you can go for something like 3.5 to 4x and you can do everything in there. And before you select the loops, do a test drive. Take the loops, do a test drive of the loops, and use them for 10 days or so. They will give it to you and then only decide, because it also matters what your eye power is. So if you have a very high eye power, then you cannot have TTL loops. You have to have a different kind of loops. So always do a test drive and check whether you're having headaches or not before you commit to using any loops. Now we come to habit A, which is within the RCT at the beginning, painless anesthesia at every visit. Now, what is the advantage of painless anesthesia? So the advantage is mainly for me. I never like it when the patient goes ah ooh in the middle of a procedure. The patient falls asleep. I can work. They don't talk once they have the rubber damp on. I'm good to go with that. Okay. And I can work faster, I can work better. So a good local anesthesia is always important. Now the problem is that as dentists, we are also afraid of local anesthesia. And what I want to do through this PPT is this. I want to make anesthesia great again. So for that, you have to understand one of the most fundamental things. First visit, second visit. So my first visit is access open BMP. My second visit is irrigation, obturation, give anesthesia in both the visits. It's not fun for the patient to feel that 10 number file going beyond even in the second visit. So give anesthesia, patients will be thankful for it. And you don't ask the patient before giving anesthesia, you just portray it as a part of the process. Now, a tip for inferior alveolar nerve block, and one of the most important blocks that we give every single day. Traditionally, we have been taught that the inferior alveolar nerve block feel that, a coronoid notch, and then you give the anesthesia. And I'm sure you have seen a lot of your blocks failing and getting repeated. That is because we are targeting the mandibular nerve, the lingula, where the mandibular nerve is coming out of. That may not always be at this position, right? So a better technique that was actually given by Dr. Angelo and Surgeon D was to give the Angelo Surgeon D block, which means as high up as possible. It is distal to the pterygomandibular raphe, just below the last cusp of the last tooth. It is as high as possible. And if you do this, your blocks will never fail. In the angular surgeon D, you go from the opposite direction. You target as high up as possible, just below the cusp of the last tooth, or even below that. There is no need to hit the bone. Just a 1.5 inch 27 gauge needle, insert 2/3 of it inside and inject. You do not need to feel the bone, hit the bone, nothing.
Ma'am,
And
below
this,
the cusp of
yeah,
third molar.
I'm sorry.
Below the cusp of third molar.
Yes, below the cusp of the third molar or the second molar, whichever is remaining. Okay, and as high up as possible. If I can go above the cusp, I do that also. Because if here you get aspiration positive, that means you are at the right spot where the mandibular nerve along with the artery is coming. So you go higher up. Okay, so you go higher up and you inject here. You don't hit the bone. You just go from the opposite direction. There is nothing extra to be done for the lingual nerve. No need to take it straight or anything from the lingual nerve. Just inject, the patient will be anesthetized. Okay. Another thing is that you need to give at least 3.6 ml of the. You need to give at least 3.6 ml of lidocaine for it to be effective. 1.8 ml hardly does anything. Another trick is that if you want to avoid that needle prick sensation, everybody sprays, but this is actually wrong. What you need to do instead is, if you want to use the cotton tweezer and spray, just spray, hold there for 1.5 minutes. If you want to use like a gel, this is available on pharmacies for like $30. Take a xylocaine 5% gel on a Q-tip, hold in the exact same position where you will puncture or put the needle, hold for 5 minutes. Gel 5 minutes, spray cotton tweezer, not spray in the mouth directly, spray on cotton tweezer, hold for 1.5 minutes. And there's another trick that works, that is buffered anesthesia. Now, what is buffered anesthesia? Buffered anesthesia basically is where it pains. One is needle prick pain, right? One is the pain of the needle prick. What is happening? Sorry, just give me a second.
And that above arrow you have to click.
Oh, yeah.
Yes, ma'am, that left hand side corner. So
Yeah, thank you. Thanks. Thank you. That's not happening. Not happening. Let's need to hold on. Okay. Yeah, buffered anesthesia. So what is buffered anesthesia? Adding sodium bicarbonate. So you get sodium bicarbonate in these vials at like 7.8 or 8.4%. You add 0.5 to 5 ml of anesthesia, and you have to make it there and then you cannot store it anywhere. So it is 0.5 ml to 5 ml of anesthesia, which is 1/10, and you inject the patient. Why buffered anesthesia? We all used to write how to make local anesthesia painless as answers. Now, why buffered anesthesia? Because the first pain can be needle prick, which we have eliminated with the topical. The second pain is the pH difference when we inject the anesthesia. We inject it slowly. That is one way to avoid it. The second way is give buffer. If the anesthesia is neutralized, the pH is neutralized, the patient doesn't even realize that they are being injected. So your anesthesia truly becomes painless, and painless dental treatment is what makes or breaks a dental practice. That is why so much emphasis on painless anesthesia. Now, for hot tooth, how do you anesthetize? You use all the blocks you have, which is your inferior for hot tooth, which is mostly your mandibular 6-7. You anesthetize with inferior alveolar nerve block, give RDK local infiltration, buccal and lingual. You give a mylohyoid nerve block, you give a long buccal nerve block, you give intraligamentary nerve block. After this, you might still have pain when you place a drop with the round bar. When you have that, you have to give intrapulpal, and that is truly what works best for hot teeth. Intrapulpal is the thing that works. The trick with intrapulpal is to give it with a lot of pressure. You have to wedge the needle and give it with a lot of pressure. Now we come to habit number 9, which is if you want to avoid ledges, what do? So the first thing that you do is you pre-curve each and every file you use. Pre-curving is very simple. You get these endo benders, but I feel that they're a waste of money. Just use the non-dominant hand, and the movement that you do is this. This is the movement, like you can see in the video. This is literally the movement against the nail. This is the movement that you do. Pre-curve all files, and the first movement that you will have is the wash binding movement with apical pressure. Now, once you have reached the apical foramen and your apex locator is telling you that is your working length, the second thing that you do prevents ledges, which is this. No. Video is. Yeah, this is the video. Yeah, so you are going to read and file at the working length, which means this stopper has to be in the same position. If the stopper is here, it always has to come back here when you are filing. When you are having the outstroke, no, sometimes what happens, we have the outstrokes, we go back in and we basically have the outstroke again before actually reaching the working length. And that is what actually leads to ledges, loss of working length or apical blockages. You need to be very, very mindful of your stopper. Again, I want to play this video because you have to be really very mindful of the stopper. You have to ream and file. This is the filing motion and I'm again going back to my stop. Every time your stopper has to touch the stop, every time you file. If you file above your working length, you are going to create a ledge. And a 15 number file can create a ledge. And a very bad ledge is that. Okay. Now, the habit number 10. This is one trick that will help you negotiate all canals. What is the first trick? T-curve. Second trick, watch fine with apical pressure. Third trick is reaming and filing at the working length, keeping the stopper at the reference point, from which you have taken the working length. Keep the reference point consistent throughout. Rotary, BMP, hand BMP, everything. Now, third, the OG trick here is, which is a little anticlimactic, is never use any file without lubricant. Now, what lubricant am I talking about here? What lubricant am I talking about here? I am talking about sodium hypochlorite. No, not EDTA gel. I have not ever owned the EDTA gel in the last so many years. So, not EDTA gel. Please, if you don't remember anything out of this PPT, throw these EDTA gels out. They are leading to blockages and perforations. Sodium hypochlorite is the only lubricant you need. Just add 1 or 2 drops of sodium hypochlorite into the chamber every time you're using a hand instrument and it is good enough. So why not EDTA? I'll tell you why not EDTA. What EDTA does is, EDTA is a chelating agent. When you put EDTA on that file and introduce it, the pulp chelates with the EDTA and forms a complex. Now that complex causes apical blockages. You would have seen it that one time we were reaching the working length, the second time I'm not reaching the working length with rotary. There is no file broken, anything. But still I'm not reaching the working length with rotary or my next file. Why? Because EDTA and pulp have formed a complex, a very hard complex, which is very hard to remove, also very difficult to remove, and has blocked your apical. So EDTA is not indicated as a lubricant. Second, EDTA with rotary is actually contraindicated. Also, EDTA causes something like this, which is your perforations. So if you want to avoid perforations, don't use EDTA. Sodium hypochlorite is best. Now, EDTA is because it affects the structure of nitae and makes it more prone to degradation and breakages. We always wrap a lot of EDTA around our rotary files thinking we are lubricating. We are not lubricating, we are just making them more prone to breakage. So do not use EDTA with rotary files. So why was EDTA gel invented if we are not supposed to use it? So the only case where it is recommended is where you have very vital, highly bleeding cases like you have in 13, 14-year-olds or a huge pulp polyp where you can't see anything. There also, how are you supposed to give it? Take the EDTA gel syringe and directly through the syringe, insert it into the chamber, not having it on your file. And then take a 10 number file and through that EDTA just do a bit of filing and then rinse with saline. Most of the pulp will be chelated with EDTA, it will stay in the coronal and you can remove it very easily. Then again, you rinse with saline and give hypo as your lubricant and continue. This was the sole reason EDTA gel was invented, not to be used as lubricant ever. Please throw them away tomorrow when you go back. Now, another, this was the 10th habit, but I could not resist adding this habit number 11 because it's going to save your patient some money. The trick to truly painless. So, when before a root canal, do you give painkillers? Or do you give after?
Ma'am?
Do you
Ma'am?
give pain?
Hello?
Yeah.
If we can't use EDTA gel, then how can we remove the smear layer, ma'am? Like EDTA gel, is main purpose is to remove smear layer, no?
That the main purpose, that is the main purpose of EDTA liquid 17% to use it as an irrigant in your irrigation portfolio. It's 1 ml
What
of
is the maximum time of hypo used in a single canal?
as much as you can. Use as long as you can, as much as you can. It is the best thing you can do. Hypo dissolves the pulp, hypo removes the biofilms, hypo dissolves the organic component, it inactivates the endotoxins. There is nothing hypo cannot do. So, bare
Ma'am,
minimum,
how to
you will
prevent
require
hyperactivity?
40.
How to
I
prevent
to prevent
hyperactivity?
hypoactivity. Use 30 gauge double side vented needle. No
So
speed,
we have
no
to
pressure.
inject the hypo.
Inject the basically in the canal. Use a silicone double side vented irrigation needle. Double side vented irrigation needle, 3 millimeters short of working length, no wedging, no pressure, no speed. Very slow speed. That is
Inject
how
the
you prevent
hypo into the
hypoxia.
canal before every 5.
If
Before every 5
hyperactivity is
watts.
occur already, then prevention or treatment plan. If hypoactivity is occur,
Hypoxia and it has almost everybody. The first thing you do is you take another 30 gauge double side vented needle, not the one you did the extrusion with, other one, take 5 ml syringe with LA and push very hard telepathically, alternate with saline and this LA till the time you have less of bleeding. Let me see, I think I have this in my PPT. I'll show you.
Ma'am, does EDTA gel or solution is mandatory, ma'am, to remove the smear layer, or NaOCl works?
For removing the smear layer, inorganic components, you need EDTA, but use EDTA liquid and not EDTA gel.
Is it
Can we use
mandatory to use,
chlorine?
ma'am?
Yes, EDTA liquid, 1 ml per canal, absolutely yes.
So in every case, we
Can
should
we
use
use
EDTA gel
chlorine?
solution, ma'am.
Yes. Okay, so this is hypoextrusion. So if you have hypoextrusion, what do you need to do? First of all, learn to recognize it. Hypoextrusion is immediate. Patient will tell you immediately, even under anesthesia, that I am having pain. Okay? Swelling may or may not occur, but if it occurs, it's instant. So if the patient calls you up after 2 hours who says, I have swelling and pain, that's a flare-up. That's not because of hypo. Hypo is immediate. Second, you will have copious bleeding from the root canal orifice, from which you extruded. You may have discoloration if you have extruded too much of it. Okay? And in cases of uppers, you may also have chlorine taste in mouth, in the throat. Now, first thing to do is stay calm. It is reversible. This was done in my practice by one of my associates. The patient mouth, the patient's face got swollen. The discoloration is hers, not done by us. At 2 weeks and 4 weeks, she is absolutely fine. Now, what do you need to do? Rinse the canal with copious amounts of LA and saline. Like I said, 30 gauge double sided needle, a new one, push periapically till the time bleeding slows. Bleeding will not stop. Bleeding will not stop because bleeding is the body's mechanism to take that toxin out. Then prescribe antibiotics, analgesics, 24 hours of cold compress for the swelling, and then warm saline rinses. If the patient is not diabetic, you can give steroids. Otherwise, let it be, and patient will be fine in 1 to 8 weeks. 8 weeks is only for discoloration. Usually in 2 weeks, they are perfect. And how does hypoextrusion look? After you have done so many of them, you start to record them like I did, and this is how it looks. Okay, there is copious bleeding. It's like a fountain of blood coming out of this orifice. I am irrigating with saline, and again it's coming out. Right? This is how copious bleeding from the root canal orifice actually looks like. But it's reversible. There's a fair amount that
Perforation
I
तब भी
have.
bleeding होती है ना, मतलब
What? Sorry.
ma'am, when we do perforation, there is also no bleeding from the how
So
to.
perforation bleeding is not this. Perforation bleeding is very different. Perforation, first of all, unless you've done like a huge ass perforation, it bleeds very little. Okay? And it is very easily controllable with a hemostat. So if it's perforation, you can see it on the X-ray, you can just insert a file there, check it on the X-ray. Second, if in hypoextrusion, you would have actually been irrigating with hypo, no? To actually extrude hypo. That is like way after the BMP is done, everything is done. So there though you have hypoextrusion because you have been irrigating with hypo. Even perforation will happen usually during access opening. And if perforation is there, just control that with hemostat gel. After that, place MTA, plug MTA there, let the patient go, let the MTA set. Okay, we come back to the last bonus habit. Now, before I was asking, painkillers before or afterwards? This one I already answered you before. Now, what painkiller do you give? What is the best painkiller for root canal, for extraction, for anything else?
25 mg.
Okay. What is the best painkiller?
Zerodol. Zerodol, ma'am.
Ibuprofen and paracetamol combination.
Yes, that is absolutely correct. It's the cheapest
Stick
option.
flow, para,
You say that
Sarashipeptides.
Serratio has no real role in it. You may not give serratiopeptidase and the patient will still be fine. Okay, so why that? Now, pain relief is maximum with paracetamol and ibuprofen. It's a very cheap analgesic. Paracetamol, basically what it does is it raises the pain threshold. And ibuprofen has a very, very rapid onset. Whatever those ketone DT people are telling, ibuprofen is more effective. Now, there was a study done. This was evaluating pain after third molar surgery. It's a fairly old article. And aceclofenac and ibuprofen, and guess what one? Ibuprofen. Ibuprofen 600 mg plus paracetamol 1000 mg is a very potent combination. It reduces pain in even the worst of cases. So you can easily give it TDS like 3 times a day, ibuprofen 400 or 600, and I always give it before starting the root canal because ibuprofen has a rapid onset and it actually prevents the prostaglandins from being released. So if you give it before your extractions, before your
ready हो गया क्यों मैम
I'm sorry.
मैम इधर ही है ना अभी मैम फ्री है क्या खाना कब कौन
I
है वो
don't understand you.
इधर ही है ओके
Okay.
Mainly
So
mute background
basically,
noise.
इधर ही है
I again am not able to understand. Is anyone asking something? Okay. So with this, we come to the end of the PPT. Thank you so much for being a very engaged and a very interactive audience. I really enjoyed the session with everyone and I hope you did too. I have my next endo workshop on 9th and 10th of May where we go further into depth into all of this, and there's a very, very, very practical aspect to these workshops. And I hope to make endodontics more stress-free and eventually earn more money from endo from there, apart from my endo workshops, we do run an academy with various kinds of courses. And if you want to contact me, these are my IDs. Please do follow me on Instagram, especially because we'll be uploading a video of the new setup, and I hope all of you will see it and give your views on it.
One
You
last
can
question
scan
I
this.
have.
And also let me know, and I'm added to the group also. If you want to text me, you can text me anytime.
Ma'am, one last question I have.
Yeah, tell me.
Tell us what about the tapers in and every tooth, like maxillary anteriors, lower anteriors, palatal and distribucal canal or distal canal of mandibular molar shed. How much till we have to prepare?
So I prefer 4%. I prepared in 44% or 45%.
Maxillary anterior teeth.
Sorry.
Maxillary upper.
Maxillary anteriors. For palatal or distal, 45%, 44% for molars. And maxillary anteriors, I am very partial to hand filing there. And I prepare till for 1 and 3 canines till at least 60, and for laterals till at least 40, 35 to 40. I hope that answered your doubts, and I will see the chat if there are any questions.
Ma'am, what will be the taper used in mesiobuccal and mesiolingual in molars and upper and like
4%, 4%,
ma'am, up
always
to
4%.
25 or 30?
Depending on the canal, 25 or 30, whichever one it is, it will be 4% taper.
Ma'am,
Ma'am,
how to decide master file, which one, up to how much should we do?
For master of 5 I think I have it here. One second. That for master, okay, I now understood what you're asking. Okay, so you are asking how to decide whether it will be 25 or 30, like the master
Yes,
of
ma'am.
5
What is the
what will be the
criteria to
master of
decide which
5
or up to which 30
Yeah,
or 4 or 25
okay,
4 or
okay,
24?
I got it.
Like in MB2, like most of the
Yeah.
cases, MB2 is constricted.
Okay. Okay, so the first thing to remember is that 25% is the bare minimum preparation that we have to do. Okay, 25% is the bare minimum preparation that we have to do always. After 25%, we can decide how much to go. Okay, now how do you decide that? So 25% is bare minimum for 25% is bare minimum. Okay, it's not here. Okay, so I'll explain. So 25% is the bare minimum you go for MB, ML, BB. After that, you take a K file, 25 K file, take it to the working length and then tap. Okay, tap on it and see whether it is going beyond or not. That is, this process is called as apical gauging. Now, for 25 4%, for 25 K file, which is 2%, for 25 6%, your tip diameter is always 25, right? So, if I am introducing a 25 K file in a canal that has been prepared, so if I am, so if this is my canal and this is my preparation with 4%, right? Now, if I am introducing a 25 K file, it should stop here, right? Because apical is same. 25 2% file is a thinner file. It is just that, it's a thinner file, right? But the apical diameter is same. It should stop here. If when I tap on it, like literally just what I'm doing is I'm just pushing from the top, literally tapping. Okay, when I tap on it, if it goes beyond, that means that naturally the apical size is greater than 25. Okay, then I will go on to 34%. After preparing 34% to working length, I will again try with the 30 K file. Okay, if the 30 K file is snug and it does not go beyond working length or tapping, that is your master apical file. Is that clear or it's still confusing?
Yes, ma'am, clear.
Will you please repeat again?
Ma'am,
Yeah.
repeat again.
Yeah, I'll show you a video I have of.
Ma'am, your voice is not clearly audible.
Oh,
Yes, ma'am. Voice could
now
break.
better?
Voice and pictures. That's why I have. That's why I said ki repeat
Kindly
again.
zoom the pictures.
Okay, okay. Just give me a second, huh? I just have. I want to see where I had the video. Yes. Can you see the video? Is the video
Yes, ma'am.
clear? No. Yeah. See, I am inserting 25 of, I am tapping like this. I am inserting 25, tapping like this. If it goes beyond, that means I have to prepare further with 34%. If it does not go beyond the working length, then it is fine. Like see this, right? I'm tapping on it and it is not going beyond. That means it is 25 is enough. If it goes beyond, like it did in one of the distance, I'm preparing further. I'm preparing with 30 or 40, I'm not sure which one is this. And then again, I will try with the K file. The piping gauging basically means that I'm trying to guess the size of the apical foramen, the natural size of the apical foramen. Okay, so I'm trying with 30. Now 30 is stuck to the working length, it is not going beyond. Okay, if that is not going beyond, that means 30 is my master file. So this step you have to do always after 25%. 25% is bare minimum for basically hypo to reach the apical. Yeah,
Okay,
tell
ma'am.
me.
Ma'am,
Ma'am, what is the correct technique?
after getting
Uh,
20,
जैसे 25 का 4, जैसे अब 30 का 4 जैसे फिट हो रहा है सपोज, ठीक है, 30 का 4 भी, अगर 30 का के फाइल अगर बियॉन्ड जा रहा है तो फिर 35 से करके देखेंगे ना.
Yes, absolutely.
ma'am, what is the correct technique for placing calcium hydroxide up to the apex in case of in pathological cases?
That actually changed. We don't place calcium hydroxide, we don't use Megapex at all. And we don't place calcium hydroxide till the apical. The reason being that, first of all, calcium hydroxide is an irritant. If it goes beyond, it's quite annoying for the patient. Second, we place calcium hydroxide till around the middle third. That is because the periodontal ligament is filled with inflammatory fluid. After you have done your BMT, that inflammatory fluid actually needs, area to relieve. Where will it relieve itself? If you give it till the apical and have no space left over, patient will keep saying pain, 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 pain. Okay. So what you do nowadays is calcium hydroxide till the middle third. Let the inflammatory fluid enter the canal. Patient will have pain relief immediately. So that is what I follow, and that's what leads to disinfection, because calcium hydroxide acts by dissociation of calcium and hydroxyl ions, and placing it in the middle third achieves the desired antibacterial effect and also gets the patient pain. So that is how I do it. And second, if you want to ask me the actual technique, then I inject calcium hydroxide. You have these silicone tips available on the entry card and with many dealers also. I buy those. I inject calcium hydroxide. Then I take a K file, 15 number K file, and agitate the calcium hydroxide till the working length, so that it goes into the dentinal tubules for disinfection. Then I inject little bit of calcium hydroxide again, and then after that Teflon temporary let the patient go. No cotton below the temporary Teflon.
Ma'am, one more question. Hello.
Yeah. Tell me.
मैम कई बार हम एक्सेस ओपनिंग बीएमपी पूरा वर्किंग लेंथ करने के बाद भी जब हम सेकेंड विजिट में बुलाते हैं पेशेंट को ऑब्जर्वेशन के लिए, तो पेशेंट को कई बार पेन होता है, सो उसमें हम एनास्थेसिया दे करके ऑब्जर्वेट कर सकते हैं क्या?
So पेन क्यों हो रहा है पहले ये देखना है, लाइक पेन क्यों है, पेन फाइल इंट्रोड्यूस करने पे है या वैसे ही है. सेकंड मेरे लिए एनेस्थीसिया इज अ गिवन, सेकंड विजिट में एनेस्थीसिया देना ही देना है, ओके
Okay.
और अगर एनेस्थीसिया के बिना फाइल इंट्रोडक्शन के देना है तो दो कारण से हो सकता है, एक कारण है कि या तो पल्प रह गया है, सेकंड कारण है इसके ओवर जा रहे हैं हम, तो ओवर में तो पेन होगा ही विदाउट एनेस्थीसिया।
Okay.
Ma'am, how
इसीलिए
do we know that we have removed all the pulp or we have cleaned enough of the canal?
we have to do, remove all the pulp and
Yes, how do we how do we know like we sure that the pulp is removed completely from the canal or the canal is completely clean?
so basically doing a BMP till around 4% using a pical gauging concept is number one. Number two, go to use a good amount of hypo. Use hypo as lubricant. The longer you use hypo, at least irrigate with sodium hypochlorite for like 20 minutes. Okay, that does the job. Main job is hypo. Hypo needs to be activated. So activate the hypo. That is the best way we can ensure that pulp is removed.
Ma'am, I have one question. I go to my friend's clinic, and what he's practicing is like after obturation, every time he is giving patient prednisolone. Like why? I don't understand. Like why to uh, to settle down the inflammation. Like he says, whenever he obturates, he is giving the prednisolone, 20 milligrams.
So basically, this was a concept that was followed like long ago. Basic the premise was that to control the inflammation and the swelling if any. But nowadays we have bioceramic sealers. They will not cause any pain. So if as long as you're not going over or anything, there won't be pain. With the after obturations. So why unnecessarily give prednisone? This was a very old concept, no? When like we didn't have that those nice sealers, the sealers used to hurt, the obturation techniques were also pretty rough. So that time it was done. Now we don't require it. I give painkillers. See, after every root canal visit, even after obturation, I tell the patient, I give before and then I tell the patient take 1 hour afterwards and take 6 hours after that. The reason being that so, as pain can occur. Post-obturation pain is normal. They might have reacted to a bit of sealer, even though bioceramics, people don't have pain at all. But even then, I still prefer just giving them a painkiller, not prednisone, just typical Brufen 400 or 600.
Ma'am, what is the reason for not using 6% rotary files?
What is the
Reason for not using 6%
sorry?
rotary files? What is the reason for not using 6% rotary files?
Yeah, so unnecessary. My aim. Why am I doing BMP? I am doing BMP so that my irrigation needle can reach 3 mm short of the earth. A pical 4 mm. 3 mm short of the working length. So if I am able to achieve that with less of dentate cutting, with 4% rotary files, then why would I use 6%? 6% cut too much. Hence, if I cut too much dentine, I'm weakening too much of the tooth.
Ma'am,
Ma'am, what about ma'am, what about yes.
मैम वन क्वेश्चन इज दिस कि एक्चुअली मोस्ट ऑफ द पेशेंट्स में हम जब सेकंड सिटिंग के लिए बुलाते हैं तो पेशेंट एसिम्प्टोमेटिक हो चुका होता है, देयर वाज नो पेन। अगर हमने कम्प्लीटली पल्प रिमूव कर दिया है एंड नो देन क्या सेकंड विजिट में तब भी एनेस्थीसिया देना ज़रूरी है इन एनी केस अगर मतलब
I find it always better. I always give anesthesia because I have seen that anesthesia along with the painkiller hardly inflammatory reaction आता है patient का कुछ नहीं आता है. So and plus I apply rubber dam. I want the patient to be relaxed. वो ये सब मुझे पसंद नहीं है. सीलर जाएगा वो भी फील होगा. I don't want to take that much of something like it's easier for me to give anesthesia and work faster. So that is why. Second, anesthesia and painkiller combined, patient को pain होता ही नहीं. That's good ना. नहीं होगा तो patient is also happy.
Ma'am, what about pro taper files? They are 8% taper. I heard that they are 8% taper.
प्रोटेपर unless and until DRCT है और किसी ने already use करके रखा है प्रोटेपर मैं use नहीं करती. I do advise I find this year.
Ma'am, which bioceramic sealer do you prefer, or do you suggest which is good efficacy?
Which what are you asking?
Which brand of bioceramic sealer will you suggest, which is
Oh,
has
I
best result?
am Angelus. I am using Angelus currently. I had used Cerasil, but मुझे Angelus better लगता है. I find Angelus better. But then Angelus is good. There is NT Biocera, which is actually quite nice. So these two brands I found that are really nice. I have used the cheaper ones also. I don't like them. And the more expensive ones though are quite unaffordable, to be honest. So I have used Cerasil. Cerasil is also good, but personally I like the flow of Angelus more. So I would prefer Angelus.
Ma'am, how do you prevent the wastage of this bioceramic sealer? Because once we place it in the tip and then insert it in the canal, the one in the tip is like after some time or days it will set. So we have to throw and then take a new tip. So how do we prevent that?
Basically, it does not set completely. So what you do is to prevent it from setting, you need to have no moisture contamination. So the minute I am done with the bioceramic sealer, the tip is sealed with a 10 number K file or whichever K file which is fitting. So that prevents the sealer from setting. So I insert like a 10 number K file into the tip, and that does the job.
Ma'am, what is the protocol for flare-up cases after obturation?
What is the protocol for what?
Flare-ups after obturation. Flare-up cases.
Sorry, I'm just not able to understand you. The protocol
Flare-up
after
cases after
observation
we do
for
obturation, patient says there is a pain, there is discomfort, and many times swelling is also there.
Flare-up is nothing. It's just for the every extrusion. Just reassure the patient, give antibiotic, analgesic, they'll be fine and sedative.
Ma'am, what is the irrigation protocol? Final irrigation protocol
ఎనీ
before
మ్యామ్
obturation?
రమ్మని చెప్పి వెయిట్ చేసాం నీకోసం
ఏంటి కన్నా?
ఎట్లా ఉంటారో రమ్మని చెప్పి అట్లా చెప్పింది డ్రెస్ అని వేస్తుండదు నేను మాట్లాడాలని చెప్పి నేను చెప్పి అరే మాట్లాడు రావే చెప్పి ముందు వెయిట్ చేస్తున్నా
I'm not able to
నా చెప్పి మ్యామ్
understand.
Ma'am, what is the final irrigation protocol before obturation?
So my irrigation protocol is 3 ml of hypo 3 times. Heat, activate. I heat it with the down pack device. Heat, activate. Then I give hypo again and do a circumferential filing with S5, and then if need be, if I still feel that I am seeing that bubbling and everything and pulp is remaining or it's a very necrotic case, then I would go for 2 or 3 times of hypo more, and my final rinse is reheated. Liquid 17%, 1 ml per canal, and then activate. Every time I'm using hypo, I'm activating it.
Also, can we use EDT as our final irrigation?
I'm sorry, can you use?
Use EDTA liquid as our final irrigation.
Yeah, you can use, why not?
Ma'am, when you shifted 2% to 4% file, why need to ditch again through endodontic or bar?
Where do we need to ditch again in the error?
Ma'am,
Ma'am,
you are showing
ma'am, what should be the ideal torque for 4% file in mesial and distal canal or in buccal or palatal canals?
Manufacturer recommendation.
Okay.
Excuse me, ma'am. Ma'am, is it possible to share the article versus that you compare between ibuprofen and aceclofenac?
Yeah, I'll share the art. I have it. I'll share the art. Not a problem.
Sure. Thank you, ma'am.
Thank
Okay,
you,
so
ma'am.
yeah, you're welcome. So I think it's
Ma'am,
12:30.
good.
Yeah, tell me.
Ma'am, you are showing that 2% to 4% while shifting. Again, again, your rotor is ditching like manner. So why, ma'am, again ditching? That
Air,
not
air
understand.
rotor. No, I did not understand. Air rotor is doing what here?
Ma'am, you are showing now. When is it's not pushing inside. It's 2% to 4%. It's 25 to 34%.
25 to 34% is the preparation I'm doing, BMP, yeah.
So need to push again. If not going inside.
You need to do what again? I think the best thing is there is some network issue that I think even I am having, and it's 12:30 and I actually do have patients waiting. So what we do is I request Dr. Sharon to just open the chat, the WhatsApp chat for some time so people can post their questions and I can reply. So that way I can also understand because I think my network. I hope that's okay with everyone.
Yes,
Yeah.
ma'am.
Yeah, Dr. Sharon, please open the WhatsApp group so that people can ask the questions they want to ask, and I can reply to the questions they have.
Yeah, I'll let you know, doctor.
Okay. All right. So, thank you so much for being here on a Sunday morning. It was a very nice session, very engaging, very interactive, and I will answer all your questions in the chat. And do connect with me on Instagram, YouTube. You have you have my number also. You can message me there. Thank you so much, everyone, and I'll take my leave now. Thank you.
Thank you so much, ma'am.